I'll be right back.
Okay, Prof. Okay, Prof. So now we are live on YouTube. I'm gonna send you the link for the YouTube.
Okay.
I will send you. I will also record as a video, Prof. But I will send you now the link for the YouTube streaming. You can share it also for those who cannot join. They can watch the YouTube at the same time.
Okay. Shall we start?
Okay, Prof. We are ready to start whenever you want. بس البروف الكاميرا عندك شوي ما هي centralized. Prof. أسعد. Prof. Asad, you can hear me? Yeah, نعم. طيب, now it's perfect.
Yes, yes.
Now we are, زي ما قلت لك, we are streaming now on YouTube and it's ready to start whenever you want. You want me to open the rooms for people to enter?
Yes.
Who's the moderator for the first session?
Dr. Ashraf الصحفي.
Okay, he's with us. Okay.
Okay, so I will open now the
Can
rooms.
I just ask you, I'll just share my slides from my desktop?
Yes, yes.
Okay.
Saad, I joined Dr. Mustafa. He's included, right, Prof?
Yes. But he's not a speaker tonight.
Okay.
So don't make him co-host, just let him join. I will open the rooms, Prof. And
Okay.
we're going to start now. Bismillah.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of BAC CDRC, I would like to thank the president of the university, Professor Al-Umar, and the vice rector of the university for postgraduate studies and research. I would like also to thank the vice dean of research here at KSU for approval to conduct this postgraduate course. I would like also to extend my thank to the Dean of the Medical College, KSU, and the Supervisor General of KSU, MC, and to the event management of KSU, MC. My sincere thank is also extended to the Chairman of Pediatric and the Head of Pediatric Gastroenterology for supporting these courses. Also, my thanks is extended to my colleague in Saudi Pediatric Association and my colleague in Susbegan Group. I would like also to thank all our international and national speakers and guests for supporting these courses, and they always support our invitation to participate in this course. I would like also to thank my colleague in the organizing committee, Dr. Shadli Saeed and Dr. Mudathir Hamid, and I would like to thank all my colleagues in the Department of Pediatrics. Thank you very much. Okay. Dr. Ashraf.
Yeah, good evening, everyone. I would like to thank the organizing committee for inviting me as a moderator in this important event in the pediatric gastroenterology scientific activity. And I would like to mention that we have two lectures in the first session. Each one is 20 minutes, and there's 10 minutes at the end for Q&A. And please chat me with a question that you would like to ask. First, I would like to introduce Carlo De Lorenzo. He's professor of pediatric at the Ohio State University and chief of the Division of Pediatric Gastroenterology at Nationwide Children's Hospital. He has been the president of North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, and has chaired both ROM 3 and ROM 4 Child Committee. Welcome, Prof. Lorenzo, and we are glad to have you, and I'm honored to introduce you to this prestigious panel. Thank you so much.
Thank you so much for having me. I have wonderful memories from last year when I was there in person. And although I'm gratified that I'm going to be able to talk to you guys by virtual of my computer, I really miss the human contact and the ability to interact with all of you. I trust that you guys are seeing my slide, the update on vomiting. Is that correct? If so, I'm going to start my presentation. I was asked to give an update on vomiting, and
Carlo, I don't see your slides.
You don't see my slides? Do you see now?
Yeah, now I see them.
Are they advancing? Is just the one big slide, or is the one with the slides on the side?
No, I think it's one big slide.
Okay, perfect. All right. Sorry for my technical difficulties, but I'm ready to go. So I was asked to give an update on vomiting. This is my disclosure. I consult for several different companies, and I will discuss unapproved and investigative uses of commercial products in my presentation, but none of the products manufactured by the companies that I consult with will be discussed. So what are my objectives? It's really to discuss the causes of recurrent vomiting. Not everything is reflux, right? Not everything that comes up is reflux. And the way I decided to structure the presentation is to have few quick clinical vignettes, and then give some teaching points about all the different conditions that can cause vomiting. Let's see if that will resonate with you guys. Here is a case, 4-month-old present with lifelong history of excessive crying and seemingly vomiting everything after each meal. Has tried many different formulas, and now he's taking a soy-based formula. It's not particularly irritable, at least in the office, but the parents are frustrated and they think that the baby has reflux. There is a normal growth and development. If you've been seeing patients in general pediatrics or in PGI for more than 2 weeks, you probably have seen a patient like this before, because this is very common. Babies spit up a lot, and I always show these slides. It's a classic slide from a study done in Chicago in healthy babies, and it shows that about 70% of all babies spit up at least once once a day between 4 and 6 months of age, and actually more than 4 times, which seems like a lot to the parents in that age range. And why do they spit up so much? Is that the pathophysiology is the same, but the symptoms change, right? The grown-ups reflux just as much as babies, but everything doesn't come up, because in babies, the esophagus is very short. It's like 8-10 centimeters. And there is a stomach that is fairly stiff. And then the babies stay laying down most of the time. So gravity doesn't protect against regurgitation. And then the biggest issue is that they assume they eat a lot for the body weight. The same amount that the baby takes in 5 or 10 minutes is about 3-4 liters for an adult. And anybody, any of us, if he swallows, if he drinks 4 liters in 10 minutes, will have some regurgitation. Hence, the commandments for infant regurgitation are always the same ones that will help decrease regurgitation, will help decrease vomiting. Acid suppression does not decrease vomiting. Thickened feeds decrease vomiting. Trying to cut down the size of the meals decrease vomiting. Avoiding pressure on the abdomen decrease vomiting. Those are the things that will help, not acid suppression. The other challenge at this age is that it's very hard to make a differential diagnosis between dietary protein allergies and true gastroesophageal reflux. Right? The symptoms are always the same. They overlap. Regurgitation, irritability, vomiting could be manifestation of a dietary protein allergy. You don't have to have bloody diarrhea. You can just have vomiting. Usually a little bit more forceful, but it's difficult to differentiate effortless from forceful vomiting in babies. And if you look at the recent guidelines published by the Aspirin and Aspirin societies, there is a beautiful algorithm that summarizes all of that, right? This is a big algorithm. If I zoom on the algorithm, you can see that first you do lifestyle changes, avoid overfeeding, thickening the feeds, continue breastfeeding if you're breastfeeding. And then if that doesn't help, if the child continues to have symptoms, then you consider a 2-4 weeks trial of a hypoallergenic hydrolysate or amino acid-based formula before even using acid suppression. That's a radical change in the guidelines, a radical change in thinking compared to the previous guidelines, because of some of the concern that have come out about chronic long-term use of acid suppression. The societies felt, try first to change the formula, the symptoms are overlapping, and if you do so before starting acid suppression, try to use the right formula, right? Try to use a hydrolysate formula. Big overlap between soy and partial hydrolysate and regular formulas, but a hydrolysate formulas is much less likely to lead to those symptoms. Switch, another case. 5-year-old vomits several times a week, usually food that were recently ingested, has some generalized abdominal pain, although sometimes he points a little bit to the chest as well, although 5-year-olds are not able to localize the pain really well, is becoming a picky eater, chews food for a long period of time. And if you ask for a family history, there's a lot of eczema, a lot of food, family history of allergies. No really abnormal findings in the physical examination. You look at the growth curve, and actually you see that there is some worrisome decrease in the percentile for the weight. What does this child have? This child is likely to have eosinophilic esophagitis. In fact, if you look at the symptoms of eosinophilic esophagitis by age, in the older patients, the classic presentation is dysphagia, food getting impacted, and then able to be washed down with more water, or sometimes vomited, or sometimes even require endoscopical disimpaction. By the younger child, the symptoms of EOE, eosinophilic esophagitis, can be vomiting. And EOE is a new condition. Actually, Dr. Winter, my co-presenter this morning, even though he's going to talk about something completely different, is one of the pioneers in the discovering a description of this condition. Vomiting in EOE tend to be a little bit more common in males. There is a familial clustering, and there seems to be an association between other manifestation of atopy and allergy. If you do a scope, this is the classic endoscopic presentation, linear furrow, micro abscesses, and esophageal rings. Those are pretty much pathognomonic. You don't have this from reflux esophagitis. You don't have this with Crohn's esophagitis. If you have this, to be honest, I don't even care very much about the results of the biopsies. You have EOE. Now, if you do the biopsy, the gold standard is still the histopathologic evaluation with more than 15 eosinophils for high power field. Treatment, PPI seems to have demonstrated some efficacy in this condition. There is a subset of EOE that is PPI responsive. not just because of the antacid properties of PPIs, but also because of some anti-inflammatory properties of PPIs. Dietary changes do help a subset of patients with EoE, and topical steroids have become a fairly common use strategy. Another vignette. 15-year-old girl presents with a 4-month history of vomiting multiple times a day, usually soon after eating. Not losing weight and has no pain. There is no nausea, no retching. It's completely effortless. It comes out in the mouth. She could re-swallow it, but sometimes she prefers to spit it out because re-swallowing it is gross, bothers her. She's not awakened from sleep. She does not have symptoms like this at night. This is a classic case of an adolescent with rumination syndrome. The diagnosis is based on the symptoms. Very few other conditions can present in this way. Repeated regurgitation or sometimes re-chewing and re-swallowing happens immediately, sometimes during the feeding. Think of any other GI disease that can do that. You cannot think of any. Achalasia doesn't do that. Gastroparesis doesn't do that. Reflux doesn't do that. That happens only with rumination. It stops at night. They don't have it food come up at night. There is no retching. You have to be careful about ruling out an eating disorder in these cases. It always tends to be more common in adolescent girls. Sometimes there is an overlap between a more classic eating disorder. The presentation is so classic that if they are in my office, I usually give them something to eat. I ask one of my nurses to give a bite of something, a cookie or a cracker, or sometimes even just a drink. They eat it, or they chew it, they swallow it, comes up right away. They have rumination syndrome. And if you really need to do a test that try to convince the parents or tries to convince the referring physicians who maybe send it to rule out a motility disorder, a manometry, either esophageal or intraduodenal, is diagnostic. And it's a big convincer because they do there, doing the test, you can show on the manometry tracing the classic waves, the classic manometric findings of rumination syndrome. Treatment is multidisciplinary. Behavioral technique are the key one. They need to interfere with the subconscious contractions of the abdominal muscles after eating that makes them vomit. We've actually found baclofen to be helpful as well, and there are some data from the adult folks that show that baclofen decreases the opening of the lower esophageal sphincter, making less likely for things to come up. And you can see here diaphragmatic breathing, hypnotherapy, and so on have been found to be helpful. Another vignette. 6-year-old is referred for 1-year history of repetitive vomiting. Happens every 4 to 6 weeks, is forceful, is repetitive, is non-bilious and non-bloody, no pain, no headache, no diarrhea. They are really sick for 2 or 3 days, vomit everything. They're actually obtunded as well. They are not quite as lucid and alert as the other days are. And often they've been gone to the ED, to the emergency room to receive IV fluids. In between symptoms, they are perfect. They have absolutely no symptoms. What do they have? They have cyclic vomiting, right? The criteria have been really well defined. The differential is pretty broad, and I'll come back to that. But the criteria are pretty classic. After you have had 2 or 3 of these episodes that have intense nausea, disabling nausea and vomiting lasting 1 or 2 days, usually fairly classic, fairly stereotypical. They always look the same in the same patients, although it may be different among different patients. Then they go away, they feel great, they're completely normal, and they come back. Sounds almost like migraines, right? And because there is an overlap between migraines and cyclic vomiting. And in fact, there is another condition called abdominal migraines, in which the presentation is very similar, wellness and then very sick, with autonomic symptoms co-occurrence. But the main symptoms in abdominal migraine is pain, in cyclic vomiting is vomiting. Treatment, you're probably quite familiar with it. You have 2 types of treatments: prevention, prophylaxis, and you use things like cyproheptadine, amitriptyline, And in most severe cases, people have used anti-seizures medications as well. And then you have abortive treatment for the acute episode to try to abort it. If you have more than 3-4 episodes a year, I put people on a preventive treatment. If they only have 1 or 2 cases per year, maybe it's worth just having a as needed intervention with fluids, antiemetics, and like the same medication people use for migraines, like sumatriptan or Zofran. Another case, 16-year-old boy presents with 1 week of nausea, vomiting, and abdominal pain. He has chronic intermittent epigastric pain that's been worsening in the previous week. Now there is severe nausea and vomiting, almost like cyclic vomit. So severe, no fever, headaches, nothing else. But then on accurate history, he admits to cannabis use. That he's now using it because he has heard that it's good for nausea. And he doesn't believe that he's contributing to the nausea. What does this patient have? As cannabinoid hyperemesis syndrome. A fairly new condition, at least in the United States. I don't know how common it is in the Middle East, but access to cannabis is very easy nowadays in the United States. It is actually, people are able to use it or to buy it in many states. The diagnosis is clinical. It's based on a good history. You need to ask. If you don't ask, you're not gonna know. I had a patient recently admitted that had a tremendous amount of workup. People were worried about vascular insufficiency. Nobody asked if he would use cannabis, and he did, and that's what he had. Cyclical episodes of nausea sometimes overlap with cyclic vomiting, alleviated by hot baths and showers. Very classic symptoms. People don't quite know why it happens, probably derangement in the endocannabinoid system. You need to be in patients who have had chronic use. Dr. Billy says sometimes it needs to be years. I've seen it in patients using it just for several months. And most patients are refractory to standard antiemetics. What is the diagnostic characteristic? As I said, severe cyclic vomiting. You need to have at least several weeks or months of cannabis use. Hot bathing helps. The symptoms go away after you make a concerted effort. Not easy, a concerted effort to stop. And it's more common in boys. Differential, very similar to cyclic vomiting. You have to make sure you rule out intracranial abnormalities or other toxins, functional vomiting. UPJ obstruction can cause intermittent vomiting, malrotation, and so on. Or, wide differential, metabolic issues, and so on. But hot bathing, relieving symptoms, is very classic. How do you treat it? Abstinence. Stop using cannabis. Dopamine antagonists such as domperidone helps. Avoidance of opiates. Opiates in this condition, for some unclear reasons, probably related to the endocannabinoid pathway, make symptoms worse. And interesting, capsaicin cream. That's something that our emergency room uses quite frequently to the abdomen, or heat to the abdomen. That probably mimics the effect of hot showers. There was a case series recently published that looked at exactly the benefit of capsaicin cream in the treatment of cannabinoid hyperemesis syndrome, and they found it to be quite helpful. It has a longer half-life than oral administration, so topical capsaicin is better than oral one. One more case scenario. 12-year-old with 5 weeks history of repeated vomiting. He starts after gastroenteritis. It's a delayed vomiting. It's the opposite of rumination. It's 3-4 hours after meal. There is nausea, and it feels better after vomiting. And the patient is losing weight because it doesn't seem to be keeping down anything. These are the patients with gastroparesis. You rule out an outlet obstruction. You do a nuclear medicine test, and you look at the 4-hour emptying. 1 hour is not that critically important. Nobody cares how much you keep down in an hour. It's the 4-hour one. If you have more than 10% left in the stomach after 4 hours, you have gastroparesis. Ignore emptying of liquids. It's irrelevant. Doesn't give you any helpful information. It has to be solid, has to be a standard meal, scrambled eggs with a classic amount of toast and jelly, and you do need to do 4 hours. How do you treat gastroparesis?
1 minute, Prof.
Small
1 minute left.
Okay. Small frequent meals, low fiber, so dietary changes. Prokinetic, we don't have many. If you have access to cisapride, use it. Domperidone, we don't have that in the United States. Azithromycin works, but you have to push the dose. Don't use low dose, use antibiotic dose unless they get side effects. 10 milligrams per kilo per dose if needed. Botox helps as well, easy to do, low hanging fruit. 25 units in each quadrant is quite beneficial, and people have demonstrated that it helps. So in summary, between all the causes of vomiting, think about character. Is effortless or forceful? Content, what do they vomit? Recently ingested food or food ingested many hours before? Timing and association with weight loss, dysphagia, such as in eosinophilic esophagitis. And here is a good summary slide for you. You have vomiting that is effortless. Think about rumination syndrome or gastroesophageal reflux. Vomiting that is forceful and episodic, cyclic vomiting syndrome, also cannabinoid hyperemesis syndrome. Diagnosis, history is critical in all of this. I gave you 6 clinical vignettes. I didn't do any test. In those 6 clinical vignettes, you could have made a diagnosis. They didn't require really a lot of testing. And the treatment on the right slide is what we're gonna need. Acid suppression for reflux, lifestyle changes, UE, we know exactly what works, dietary changes, medications, and PPI, cyclic vomiting, I discussed that, rumination syndrome. Don't miss rumination syndrome. It's more common than you think. A lot of people miss it for years, and we see these patients after many years. Gastroparesis, prokinetics, Botox, sometimes even gastric pacing, and CHS make them stop having cannabinoid. Thank you so much for your attention. These are some key references. I'm looking forward to meeting you again in an hour or two for the next talk, and for the Q&A in a few minutes. Thank you for your attention.
Thank you, Prof. Lorenzo, for this nice overview of the vomiting and the update. And we'll leave the question after the second lecture. That will be on early onset IBD. We are honored to have Prof. Harland Winter. He's pediatric at Harvard Medical School, General Hospital for Children. He is the director of the inflammatory bowel disease program, and he also was the president of NASPGHAN between 1998 to 2000. He also contributed to a very large scientific event, which is the World Congress for Pediatric Gastroenterology. That was in 2000. He has a numerous publication and his interest in the IBD. And we are honored to have him to present the early onset IBD. Thank you, Dr. Winter, and the floor is yours. Thank you.
Well, thank you very much. Can you see my slides all right?
Not yet.
No?
No.
You share them?
I do. But
You're seeing a black screen now.
The desktop is there.
do you see the slides now or not?
We see the desktop. I think you need to pick a different screen.
Okay.
You might have 2 screens, maybe.
I do have 2 screens. That may be part of the problem. Let me see.
I think when you share, it's supposed to give you some choices.
Yeah. Is that
Yeah.
better?
Yeah,
Yes.
but we see all the slides on the side as well.
Okay, let me see if I can. I'm clicking slideshow, but it doesn't seem to. Oh, okay.
No.
That's good now?
Yes, yes.
Okay. All right. Thank you. Well, I want to thank you very much for asking me to give this talk on inflammatory bowel disease. And like Carlo, I miss being able to see my friends and thinking about the wonderful time that we had when we were in Riyadh together. And I hope that we can be together again soon. I'm going to talk for the next 20 minutes about early onset IBD. And I want to start by just providing a definition so we know sort of where we are. A very early onset IBD refers to onset of IBD less than 6 years of age. And early onset IBD usually refers to onset of IBD between 6 and 18 years of age. So there's been some discussion about these definitions, but this is what people have settled on in terms of defining these two different presentations of IBD. I want to refer you to a study that was done, a cohort study that was done in France of over 1,400 pediatric patients who were less than 17 years of age. And they looked at the incidence and the phenotype at diagnosis of very early onset IBD and later onset IBD in terms of outcomes. And you can see in these two figures that the bottom line shows the incidence of very early onset IBD over a number of years, starting back in the 1980s. And on the slide on the right breaks it down by very early onset IBD in Crohn's disease and in ulcerative colitis. And you can see that for both Crohn's disease and ulcerative colitis, very early onset IBD, less than age 6, has been pretty constant over the years. There's not been a tremendous increase in incidence. But if you compare that to the top lines, which are early onset IBD, including over the age of 6 to 18, the incidence has been increasing dramatically. And this is something that we've seen throughout the world. There have been reports from the Kingdom of similar findings, from Canada, from the United States, from Europe, that inflammatory bowel disease is increasing in incidence, and that we're seeing it throughout the world. The other feature that came from this study was that rectal bleeding and having mucus in the stool were more common in very early onset IBD, whereas weight loss and abdominal pain were more frequent in the older children. So there are some differences, largely due to the fact that very early onset IBD is mostly a colonic disease, so you would expect bleeding and mucus in the stool to occur in that population. The people have looked for associations between very early onset IBD and certain conditions, and the fact that the incidence has remained at a similar rate over many decades suggests the fact that it's genetically driven. And there have been a number of studies looking at genes in very early onset IBD, and we'll talk a little bit more about that later in the talk. But basically, looking for monogenic defects has been a key area of research. And while there have been a number of monogenic conditions that have been described, it's generally about 15 to 20%. So it's not a large majority of the patients. A large majority of very early onset IBD have reasons that are unclear. But in a cohort study of over 800,000 Swedish children who were born over 7 years from 2006 to 2013, the associations were looked at in terms of possible associations with the onset of very early onset IBD. And what they found was that there was an association between exposure to antibiotics in the mother, especially during the 3rd trimester, and the subsequent development of very early onset IBD. There was no association between antibiotic exposure in children and subsequent development of very early onset IBD. I want to emphasize this is an association. It's not causality. It's an association. So we really don't know what the reason is for this association. So the North American Society, NASPGHAN, put out a position paper last year looking at the evaluation and management of patients with very early onset IBD. And I think that it's worthwhile looking at some of their recommendations and some of their findings, because this is really the major paper that deals with very early onset IBD. management and diagnosis. So as I mentioned, about 15 to 20% of patients with very early onset IBD will have an identified monogenic defect. So it's not the vast majority. There are about 50 genetic defects that have been identified, and they fall into roughly 4 different categories: intestinal epithelial barrier function, phagocyte bacterial killing defects, hyper or autoimmune inflammatory pathway abnormalities, and dysfunction of the adaptive immune system. So we're going to talk a little bit about each of those areas from a clinical standpoint, so that hopefully by the end of the talk, you'll be able to know when to suspect an infant as having a very early onset IBD. So defects in intestinal barrier, epithelial barrier function are either, they can be loss of function mutations or gain of function mutations. And they're listed on this slide, but I'm not going to go through each of them. But the important message is that most of these conditions, especially in the loss of function mutations, have skin abnormalities associated with them. So there's some that you've probably heard of, NEMO, which is an X-linked ectodermal dysplasia and immunodeficiency syndrome. Most of them are associated with skin abnormalities, epidermolysis bullosa, or eczema or other conditions. So one thing, if you have a patient who's got bloody diarrhea in infancy and skin conditions, you should certainly think about a defect in intestinal epithelial barrier function that could be associated with early onset IBD. Phagocyte killing abnormalities, the most common one is chronic granulomatous disease. And as we've looked at the defective NADPH oxidase complex deficiencies that result in a defect in superoxide production that leads to an ineffective intracellular killing of microbes, these individuals with chronic granulomatous disease often have associated inflammatory bowel disease or colitis, usually associated with them. They often have a characteristic biopsy with these Michaelis-Menten bodies, but they also have monogenic defects in CGD, which are associated with early onset IBD. And I've listed 5 of these mutations on the slide. But what's important to know is that sometimes patients will only have one of these mutations and may have a second mutation that's not been identified, but they still may fall in the category of having a variant of chronic granulomatous disease. There are also defects in motility of the immune system, like the leukocyte adhesion deficiencies that can be associated with the development of colitis in infancy. Hyper or autoimmune inflammatory pathways are the third group of patients that can present with very early onset IBD. And the variants in IL-10 or IL-10 receptor pathway mutations in these genes can lead to very early onset IBD. One of the hallmarks is having a perianal fistula at a young age, and you can see in the slide down in the bottom left, this is an infant who had these 2 perianal fistulae and was diagnosed with an IL-10 mutation defect. The colonoscopy on this next slide looks very similar to what we see in Crohn's disease, and even this is an older child, but you can see that the imaging study shows this comb sign, which are dilated vessels in the intestine, in the mesentery, that are typical of inflammation. And this is an older child who has a persistent perianal fistula, who has an IL-10 receptor abnormality. Perianal fistulae, chronic diarrhea, arthritis, and skin rash or folliculitis are common in the early phases of IL-10 receptor deficiencies. But lymphoma has been seen in adolescents who previously were not diagnosed as having an IL-10 receptor deficiency. So in an adolescent with lymphoma who has any GI symptoms, one should think about looking for IL-10. There are other inflammatory pathways that can be involved in very early onset IBD. Some of the genes associated with familial Mediterranean fever have been associated with early onset IBD, hyper-IgE syndromes, and then abnormalities in X-linked lymphoproliferative syndrome, defects in XIAP, which is one of the genes that's associated with NOD2 signaling, can result in severe colonic disease, and again, perianal fistulizing disease, which needs to be distinguished from IL-10 and IL-10 receptor defects. One of the important clinical aspects of XIAP is that there's association with fatal hemophagocytic lymphohistiocytosis, which is triggered by EBV infections. These patients do not handle EBV infections very well and can develop into a fatal disease. And finally, there's a genetic defect that's been recently described, TRIM22, which results in defective NOD2 signaling, and this results in, again, inability to handle intracellular organisms. And finally, there are regulatory T cell defects. There's that result in enteropathy and colitis. So this is an example of IPEX syndrome, and one of the clues to this immunodysregulation, polyendocrinopathy, enteropathy with X-linked syndrome, IPEX, which is caused by mutations in the FOXP3 gene, is that they have both not only colitis, which is the most common aspect of very early onset IBD, but they also have enteritis. So they have an enteropathy. They often have villus atrophy. And you can see on this slide, this is a small bowel biopsy showing as a flat villus lesion. But then after a bone marrow transplant, the intestine starts to regenerate itself. These patients also have this plaque-like psoriasis, which goes along with the IPEX abnormalities. There are other disorders that cause a similar IPEX-like disease that only can be discovered through whole exome sequencing, and the loss of function mutation in IL-2 receptor, and also a gain of function mutation in STAT1 can result in similar diseases. And then there are dysfunctions in the adaptive immune system, severe combined immunodeficiency, common variable immunodeficiency can present in the first 6 years of life, a CTLA-4 deficiency, which is associated with lymphadenopathy and splenomegaly, and lymphocyte infiltration that can involve not only the GI tract, but also the brain and the lung. And there are other loss of functions mutations that can cause similar immune abnormalities. Wiskott-Aldrich syndrome can present in the first six years of life and is characterized by thrombocytopenia and eczema. Usually, Wiskott-Aldrich syndrome only involves the colon. So what's the evaluation? Where do you start with trying to look at a child who's under 6 years of age who has evidence of inflammatory bowel disease, has chronic colitis? Well, the immune workup should include immunoglobulins, subclasses, and then some assessment of the functionality of the immune system. So one of the best ways to test the functionality of the immune system is to look at antibody production, because antibody production requires macrophage function, T cell function, and B cell function. So if your antibody response is robust to certain antigens, that suggests that your immune system is functional. Tetanus is a measure of IgG1, and pneumococcus and Haemophilus are both encapsulated organisms, and they assess IgG2 response. So if you've got responses to tetanus, pneumococcus, and Haemophilus, it suggests that your functional immune system is intact. To look for CGD, you want to do the DHR test, which is a functional test looking at superoxide release. And then if you want to look at most of the genetic tests, you can do a flow cytometry test for XIAP. You can also look at lymphocyte subsets for many of the immune abnormality defects. But I want to point out to you a resource that is very valuable, and it's a resource by Invitae, a primary immune deficiency panel, which analyzes 407 genes that are associated with inherited disorders of the immune system. And I list the website here so that you can go on the website and get access to it. You can order the test. It comes back pretty quickly. And it's a very good screen in early onset IBD, and even for patients who have IBD, early onset IBD, not necessarily very early onset, to look for possible inherited mutations. This covers most of the genes that are known to be associated with inflammatory bowel disease, and is a relatively easily available test to do. So the other aspect of early onset IBD are what are the outcomes of this condition? We know that certainly a number of these patients go on to develop to have surgical intervention if they don't respond to medical therapy. Treatment really depends upon the diagnosis, which we need to establish, and which we won't have a definite diagnosis of a genetic cause in about 80% of patients. So we're left with a number of patients for whom we treat with a variety of medications. One of the medications which I think is underutilized in young infants is to use vancomycin, which has been shown to be beneficial in colitis, especially in younger children. But the Swedish registry did a large study, as only can be done in Sweden, looking at childhood onset IBD. So these are children who range in age from infancy up to 18 years of age. So it includes early onset IBD. And they looked at groups, at patients who were diagnosed between 1964 and 2001, and then after 2002. And they looked for complications of the disease. And what was striking is if you look at the IBD patients, and you look at the non-IBD, the IBD patients are in blue, the non-IBD patients are in this reddish color. In the slide on the left is the data from 1964 to 2001, and notice that the proportion of patients with cancer is 0.1 and 0.2 compared to the group from 2002 to 2014, where the ordinate is 0.01. So it's a tenth of this value. But you can see that in both cases, both in the older patients and in the more recent ones, that there's a significant increase in cancer risk in patients who had early onset IBD. Well, what are those cancers? What's driving it? And this is sort of a summary of what's driving that cancer risk. And you can see that liver and colorectal cancers and small bowel drive it the most, although the small bowel is a very small number of patients, only 5, so I don't know how reliable that is, but certainly colorectal and liver, and also skin cancers. I mean, non-melanoma skin cancers. That we've seen that. And that's also interestingly been in the developed database. Skin cancers were one of the malignancies that showed up in patients who had Crohn's disease, who have been followed for now about 7 or 8 years. So we need to look at these patients longer term, make sure they see a dermatologist for a regular basis. We used to say they should see an ophthalmologist, but we've added dermatology to that list now. And then they do need screening for colon cancer as they get older, because they are at increased risk. So
2 minutes.
I'm sorry, this is the last slide. So the take-home points from the talk are the incidence of very early onset IBD seems to be constant, which suggests a genetic predisposition, although we only see it in less than 20% of patients. But the incidence of early onset IBD is certainly increasing. That antibiotics in the third trimester of pregnancy seem to be associated with very early onset IBD. It's not causality. Children with very early onset IBD should have an immunologic workup, including tests for monogenic diseases, even though only 20% will be found. And the long-term risks include an increased risk of cancer, mostly skin and colorectal, which should be monitored over time. And with that, I think I can stop sharing. Thank you very much for your attention, and we're happy to answer any questions.
Thank you, Prof. Winter, for your nice overview about the early onset IBD. We have some question that we have. The first question is for Prof. Lorenzo regarding, just let me pull up the, there's a question to Prof. Lorenzo. Is the use of PPI is recommended in confirmed cases of eosinophilic esophagitis, or only diet steroid is enough?
So that's an excellent question, because the field of eosinophilic esophagitis is going through a little bit of a shift in focus. The old recommendations were you first give PPIs to patients, and then you even wait to do the endoscopy to find out if there were patients who responded to PPI who will not have evidence of eosinophilic esophagitis once you scope them. Now the field has changed and said, don't start treating them. Do the endoscopy first. Don't put them on PPI. Once you find a EOE, then you can choose. And the data are fairly convincing. There is a subgroup of patients who responds to PPI. So in my mind, if you find I will work with allergists. If you find a allergen that is obviously causing symptom on that patient, you take that away. Otherwise, I still like to treat them with a PPI first, and then see if they don't respond, then I go to either dietary or steroid, topical steroid therapy. So before was everybody PPI, now is subgroup of patients on PPI.
Thank you. There's a question from Dr. Winter to you, Prof. Lorenzo. The questions say that what can be done to prevent avoidant restrictive food intake disorder after episode of vomiting?
Yeah, that's a tough question, not as tough as the other one that he wrote in the question and answer section. But that's a tough one, because which one came first is sometimes difficult to tell, right? So ARFID, avoidance food intake disorders, are probably becoming the most common form of eating disorders. They're not as dramatic as the bulimia, anorexia nervosa, but they're very common, and they can lead to fairly severe consequences. Sometimes the patients tell you they are afraid of eating because they are scared of vomiting. They don't want to get nauseated. They are terrified of vomiting. So that's why they stop eating. Other times, they vomit or they get nauseated because they have ARFID to start with. They get anxious, and that makes them nauseated. So I don't know which one comes first. It's not an easy solution. Sometimes you need just to discuss it. Sometimes I bring it up. Parents, do you think that this may be a form of eating disorder as well? And you need to have a frank conversation. Sometimes I have our adolescent medicine expert help me in differentiate which one came first. But often it's very difficult. They are really overlapping. There is a Venn diagram with a big overlap. So I don't have an easy answer to that one.
Thank you, Dr. Lorenzo. I think there is only 1 minute left for the question, but there's a question to Dr. Winter regarding shall we rule out immune deficiency, especially CGD, for all visualizing VOD IBD before starting biological therapy?
It was a question of should you work up patients for CGD before starting therapy? Was that the...
Yes. Yeah.
Well, I think that working a patient up for possible CGD or for the genetic abnormalities associated with CGD is part of the workup. And if you do that in vitae a genetic screen, you'll obtain information about genes associated with CGD. So I think, and the treatment is different. If somebody has CGD, you're going to treat them differently, and you might treat them, with a different medication than you would if they have IBD. So gamma interferon has been used, for example, very successfully in patients who have CGD and IBD. So whereas it would not be useful in patients who have inflammatory bowel disease. So I think it is important to make that distinction.
A follow-up to this question, what's the recommended, because sometimes the immune deficiency and genetic workup will take time, and patient, they are really sick and we have to start something. What's the recommended initial therapy? Just vancomycin, or to add something to buy the time till you get the result and establish the final diagnosis?
Yeah, well, it depends, I think, upon the the seriousness of the colitis, because most of these patients have colitis. I think vancomycin is often the drug that I would start with, but I would move to corticosteroids if that were the case. I mean, if it's possible, giving something like Uceris would be a medication if they were older that you could try. But I think that's really the arsenal right now. I'd be hesitant to start an anti-TNF agent unless I had some immune workup done, completed initially. It takes about 2 to 3 weeks to get the results of that 407 gene panel, so it comes back pretty quickly. So if you think about it early on, by the time you've treated the patient and assessed their response, you'll have the result back. Also, I think nutritional therapy can be beneficial in terms of using an amino acid based formula may minimize the immune response in the gut. So, I mean, those are some of the options that one has until one has a diagnosis. If all the genetic tests are negative, then one needs to think about treating them with biologic agents.
Thank you so much. At this time, we'll conclude this session. I would like to thank all the speakers for the great talk, and for the audience for the good questions that they sent to me. There's some questions that I don't have time to ask, but we'll forward that to Professor later on, just to if there's any answer, will be sent back to the audience. Thank you so much, and hand over the session to Prof. Badria for the second talk. Thank you.
Okay, Assalamu alaikum. Good evening, everybody. And initially, I would like to thank the organizing committee for inviting me to participate in this very important, actually, pediatric gastroenterology course. This is the 9th year for the Middle East course, and actually, it's my honor and pleasure to participate as a moderator for this second session for tonight, which is actually a very wonderful and excellent scientific evening. Initially, I would like to introduce, for the one who has joined us recently, Professor Lorenzo. He's a professor of pediatric at the Ohio State University and the chief of the division of the pediatric gastroenterology at Nationwide Children's Hospital. He's well known to all of you. He's an eminent speaker. He has been the president of the North American Society for the Pediatric Gastroenterology, Hepatology, and Nutrition. And he has chaired both the Rome 3 and Rome 4 child and adolescent committees. On behalf of all of you, I would like to welcome you, Doctor, and it's our honor actually to have you this evening. So you are welcome for the second speak, please. And it will be about constipation, which is a very common disorder in the childhood. So you are welcome, doctor, and you can start your speak.
Thank you so much once again for this very kind introduction. I trust that this time you actually can see my slides. I hope that that's correct. Dr. Winter, can you give me feedback there? Can you see the slides? Okay.
Yes, yeah, I can see them.
Okay. In that case, let's see if I can advance them. Okay, so I'm going to ask, I was asked to give an update on constipation, and I really decided to focus only on the treatment part, because to be honest, there is not a lot of new information about the diagnosis and the epidemiology or the pathophysiology of constipation. So I'm going to focus the next 20 minutes just on the treatment of constipation and emphasize some of the novelties that applied to our interventions. This is the classic treatment pyramid, right? Every disease has a pyramid. IBD, I'm sure, has it as well. So does reflux, everything else. The pyramid always has more common benign interventions at the base that work on most patients. And then the more you go towards the apex of the pyramid, you have usually more aggressive, sometimes more costly, sometimes more invasive interventions that apply to a very selected group of patients that tend not to respond to the most of the interventions. And that's exactly what it is for constipation. There is things like education, toilet program, osmotic laxatives, and so on that help 70–80% of the patients. And then there are fewer interventions that are needed in the remaining of the patients. So what's new? Okay, first, a couple of things about some old drugs, because there are some novel information about some of the old drugs. Why? Because some concern have transpired. For example, one, if not the most common used medication, polyethylene glycol, 3350 or 4000, as often used in Europe, has raised the concern that there may be some behavioral problem, neuropsychiatric events that have been associated with its use. There is a very active, very vocal group of lay people, parents, and advocates for patients who have been exposed to polyethylene glycol that fear that some of the problems that the children had were caused, or at least worsened, by polyethylene glycol. And these are the events that have been associated. Anything from seizure, tremors, tics, anxiety, lethargy. So a variety of different neuropsychiatric events. And the reason why people were worried is that 3350 is actually the average molecular weight of the compound that is in the commercial product. But there are some minuscule amount of other polyethylene glycol that are monoethylene glycol, diethylene glycol, triethylene glycol, smaller molecules. They could cross the gut-brain barrier and could, in theory, affect your CNS. Now, the problem is that many of the patients that develop functional constipation in children, many of the pediatric patients already have neuropsychiatric symptoms to start with, behavioral symptoms to start with. This is a study that we published a few years ago in collaboration with our colleagues in the Netherlands, and we looked at children coming to a clinic without being treated first, without having ever received polyethylene glycol, with a chief complaint of constipation. And you can see here that 1/3, 27 out of 97, had already positive screening on questionnaires for behavioral problems. So to start with, 1/3 of patients has a behavioral problem or what they could be considered neuropsychiatric symptoms. So which one came first? Sometimes the behavioral problem came first, right? Then we did another study that we published a couple of years ago. We measured blood level, serum level of those small metabolites in patients exposed to polyethylene glycol 3350, in this case was Miralax, and patients who had never been exposed to. And we found, look here, more ethylene glycol, diethylene glycol, triethylene glycol, control patients who were never constipated, and patients who were receiving polyethylene glycol. We found absolutely no difference in the blood level of those compounds. So we felt that it's unlikely that that's a cause and effect relationship between being exposed to those compounds and developing neuropsychiatric events. Now, that being said, I remind people there is no need to take these laxatives. If you're worried about it, there is nothing special about it except the taste. It's not a miracle laxative. This is another study that compares milk of magnesia, a very old stool softener, has been around for ages, probably 50 years, probably older than Dr. Winter. And they compare that to Miralax. And they found out that, for example, polyethylene glycol and 3350 and milk of magnesia were equally effective. The only difference was patients were taking the polyethylene glycol because was not as foul tasting. Milk of magnesia didn't taste good, polyethylene glycol had no taste. So compliance was better, but if you prefer to use something else, go ahead and use it. Another concern, stimulant laxatives. I feel very strongly that are underutilized. Bisacodyl, Fena, have been around also forever. They've been this idea that you become addicted to this stimulant laxative. No credible scientific evidence exists that that's the case. People underutilize stimulant laxatives. The problem is there have been not a lot of studies because they've been around forever. This is a study showing bisacodyl is safe and effective in adults. Another study done by our center looked at high doses Senna in patients seen in a colorectal clinic, some of them with surgical issues as well. And they concluded that Senna is safe and effective. There was no relationship between long-term administration and any type of mucosal or systemic problems. The only thing they found is very high doses, really high doses, were causing a dermatitis that would resolve once you stop using them. And another study published last week compared magnesium and Senna in adults, randomized to placebo, Senna, magnesium, and they found that Senna was as good as magnesium in those patients in increasing frequency of bowel movements and increasing quality of life, and they found no side effects. So use them. Don't be afraid of stimulant laxatives. That being said, let's talk about the new drugs. Who needs new drugs? These are the patients who need new drugs. There was a classic study done by Mark Beninga and his group in the Netherlands. They found that a subgroup of patients, even after 7-8 years of being treated, which is a really long time, 7-8 years of being treated for constipation, still doesn't do well. Look at the percentage in red. Those are patients that have no success despite use of laxatives. So those patients, after 7-8 years, I would recommend that you think of something else. Maybe it's try to use different medications. What are different medications? These are new drugs. They have a different mechanism of action. Look at them. Many new drugs. We have as many new drugs in treatment of constipation as our colleagues have in the treatment of IBD. And those are all the ones approved in the United States. Look at that. They work on the CGMP or other secretagogue mechanism. They increase water secretion in the GI tract. Others work on serotonin receptors, like prucalopride. Other works on bile acid transporters in the terminal ileum. And we have 6 that have been approved for use in adults only with chronic constipation in the United States. And here is a study. Look who is the first author, Dr. Winter, who doesn't do just IBD, but actually does reflux and eosinophilic esophagitis and even constipation. Amazing young man. What we did, I was part of the study, we saw that on an open label study, giving prucalopride helped improving frequency of bowel movements. Here is after the graph shows the frequency of bowel movements after starting prucalopride. You can see 7-8 bowel movements per week, in these patients. So open label study shows some benefit of prucalopride. Unfortunately, a double-blind, multi-center, randomized, very well-designed study showed no benefit compared to placebo. That was true for prucalopride, and linaclotide, who is also another compound that has been approved, very similar to lubiprostone, another secretagogue. They stimulate, this one stimulate cyclic GMP in the small bowel. and leads to ileal secretion, accelerates transit, actually seems to be also hypoalgesic, decreases pain in the small bowel, led to its approval in 2012 with a black box warning against its use in children younger than 7, and some warning about use in children younger than 17. That because it was causing diarrhea in those patients. So I actually use it. I actually use it a lot, I have to be honest, in patients giving informed consent, but I found it to be quite effective. Now, once again, there was some evidence that he will have some benefit in an open label trial, some benefit in adults, and in a double-blind randomized trial that we just reported at DDW, we reported that compared to placebo, patients receiving linaclotide, and actually there is a similar study on lubiprostone as well, were not likely to have an increased advantage over placebo. But it was deemed and found to be safe in those patients. So at least the safety data seem to indicate that it is as safe as it was found to be in adults. It was very well tolerated. What else? What behind medication? I told you there are 6. I didn't have time to discuss all 6, but all 6 are available in the United States off-label in children. There is something that actually is becoming increasingly used, especially in Europe, I need to say, not quite as much, but it's being used in the United States as well. This is, if you want, an advanced use of enemas. It's called the peristeen, and it's a rectal irrigation system. You put some fluids, you block the immediate expulsion to it with a cone, and you allow it to have some efficacy, and then eventually you empty the distal colon. There was a study done in the Netherlands as well that looked at a variety of patients, and 91 patients, so fairly large sample of patients, open label. You cannot do a blind study of an enema intervention. And they found that 86% of parents were satisfied with the results of the transanal irrigation. So pretty high level of satisfaction for something that is not very invasive. And interesting, was fairly well accepted by the patients. They concluded that transanal irrigation may be effective in the treatment of children with functional constipation. What else? Botulinum toxin is another intervention that is not dramatically invasive. It's a little bit more invasive, obviously, than a medication, but doesn't require surgery. It requires a short general anesthesia, and you can inject botulinum toxin. Usually we use 100 units divided in 4 quadrants, 25 units in each quadrant. Sometimes we go a little higher in the older patients. In the anus, you probably inject both internal and external sphincter. It's tough to differentiate exactly what sphincter you inject, but it's been found to be helpful. This is a group of patients that had a condition called anal achalasia, in which you have a non-relaxing anal sphincter in the presence of ganglion cells. So it is not Hirschsprung, but still shares some pathophysiologic abnormalities with Hirschsprung. And you can see here that many patients have improved and continue to improve up to 1 year after the injection. Another study by the group of Leonel Rodriguez, when he was still in Boston, looked at patients with anal sphincter dysfunction. Once again, patients with either Hirschsprung or anal achalasia. And he found that injecting botulinum toxin into the sphincter led to significant improvement in almost everybody, 22 out of 24 patients, for an intervention that is not very invasive. And interestingly, the duration of effect was variable, with half of the patient lasting more than 6 months. You think of the effect of Botox usually to be 3-4 months, but some of the patients probably overcome the fear of defecation. They may have some benefits on the pelvic floor. They may not need it after 6 months or so. Interesting, another study done actually at Mass General by Claire Zark-Kessler, and when Dr. Berkin-Gerson was there, looked at patients that received Botox injection regardless of the anal dysfunction. So the previous one, you had to demonstrate an anal dysfunction. This one is all comers, all patients who fail to respond to laxatives. And they did 164 patients. That's a large cohort of patients. And what they found is 70% had positive response. And that was irrespective of the pre-existent reason to be constipated. And they have very little side effects, not particularly disturbing, just some fecal incontinence that improved with time. What else? Fecal nerve stimulation, a little bit more invasive. We're getting to the tip of the pyramid. This is a device that is like a pacemaker inserted behind the gluteal muscles in the back that is linked to the sacral nerve, stimulates the sacral nerve, and has been found to help patients with bladder dysfunction for many years. Our urologists have used this technique to help bladder function for many, many years. And then they found actually helped constipation and helped fecal incontinence as well. So once again, our Dutch colleagues began to use it and they found it to be helpful in children, adolescents with refractory constipation. You can see here the Cleveland Clinic constipation score going dramatically down after being inserted. And since that time, there have been a variety of other interventions. Here is probably difficult to read, but those are many studies, some of them from our group. They found that the application of the sacral nerve stimulator in a subgroup of patients who had failed many other interventions was quite helpful, especially for fecal incontinence. Think about that in patients with fecal incontinence, especially if they have also urinary problems. Then it becomes a win-win situation. Helps the bladder, helps the incontinence, fecal incontinence as well. There are other non-invasive ways to deal with this, maybe with abdominal stimulation, transabdominal electrical stimulation that has been found, especially in Australia, to be helpful. And then there is another intervention that actually we are doing a study about, posterior tibial nerve stimulation. You can actually stimulate the sacral nerve by stimulating the posterior tibial nerve. Maybe, if effective, will obviate the need for surgery to stimulate the sacral nerve. Finally, antegrade enemas. Those are very helpful, especially in patients with fecal incontinence that have responded poorly to medical interventions. I find sometimes that the physicians are resistant to one. Family wants something new. It's the opposite of a gastrostomy. Usually gastrostomy, the physician wants to do it, and the family are against it. For this, family are sick and tired of having a child that needs to wear diapers, even if it is 12-year-old. They want something new. With the cecostomy and administration of antegrade enemas, you're able to provide that benefit. You clean the entire colon. You keep them clean, finally, after years. This is a beautiful study that looked at 105 patients done by the group at Boston Children's and with Sam Nurko. Look at the benefit in everything: functional constipation, myelodysplasia, anorectal malformation, anal achalasia, cerebral palsy. Some side effects, but overall, think about it, use a stimulant, adjust the volume. You have to target the treatment, the flushing to the response. Be aware of retrograde flow. Sometimes you can have a retrograde flow in the terminal ileum. Patients get nauseated, get sick. So patients not doing well, do a bioenema from the antegrade, from the cecostomy or the appendicostomy, see what happened to it. And remember, the ascending colon eventually will dilate. They may not work as well with time. Finally, this is a study that showed that the colonic resection, this is a very tip of the iceberg, right? The tip of the pyramid. Once everything else fails, a colonic resection may be helpful. It's a complex intervention. Patients need to have failed everything else, need to have a very poor quality of life. We always do now antegrade enema first, cecostomy. If that fails, they don't do well anymore. Consider maybe the resection of the very dilated rectosigmoid colon. Sometimes that's the only thing that will help this very specialized subgroup, selected subgroup of patients. Thank you so much for your attention. I'm going to look forward once again to your question after an enlightening lecture by Dr. Winter. Thank you so much.
Thank you very much, Professor, for this wonderful and highly informative lectures, actually on updates of constipation especially the refractory constipation. Now we will move to I think all the questions we can wait at the end of the session. Now we move to the second talk, which will be delivered by Professor Winter. All of you know about him already. This is for this evening. This is the second talk for him. He is a distinguished and eminent speaker in the field of the inflammatory bowel disease. Professor Winter, he's a professor of pediatrics at Harvard Medical School and Massachusetts General Hospital for Children. He's the director of the Inflammatory Bowel Disease Program. He has been president for the NASPGHAN and between 1998 and 2000, and he has organized the first World Congress of Pediatric Gastroenterology, Hepatology, and Nutrition in Boston in 2000. He has many researches and clinical trials in IBD, and in his scientific achievement also include the discovery in 2012 of a new disorder of chronic diarrhea, actually in the diarrhea that's found in the first week of the life of the babies. You are welcome, the professor, and on behalf of all the audience, we welcome you. It's our honor to have you, Professor.
No, thank you very much. I have to see where to, let's see, share the screen. Can you see the slides now?
Yes, Professor, we can see, but if you make it on the...
Yeah, I'm trying to, there it goes. Is that the right view? Yeah,
yes,
great, thank you.
Yes.
Thank you. Well, I want to thank you again for asking me to give this talk, and especially to be with my dear friend, Dr. DiLorenzo, who I always learn something when he gives a talk, and I learned a little bit about constipation, but it's been a long time since I worked with Charles Henry Phillips, who developed milk of magnesia in 1872. He's a little bit older than I am, but not much. We're going to talk for the next 20 minutes about new therapies and new biologics in IBD, and this has been an area that's been dramatically changing over time. I just wanted to briefly review some of the clinical features of Crohn's disease and ulcerative colitis, which all of you have seen. Crohn's disease can involve the lips, and this is a patient that I saw many years ago. He was about 6 years old. He's now almost 30, and he started out having Crohn's of his lips and colitis, granulomatous colitis, and now he has an ileostomy because he has colitis throughout his entire GI tract and has Crohn's disease. Perianal skin tags, extraintestinal manifestations like pyoderma gangrenosum, typical areas of aphthoid lesions with areas that look normal next to it, to areas where there's cobblestoning and a lot of edema and lymphoid hyperplasia in the GI tract, and then stricturing formation. And this is a resection which shows nicely areas of ulceration adjacent to areas that look fairly normal. In Crohn's disease, this is a resected specimen of the ileum, and you can see this area, this markedly thickening fibrosis, these areas of ulceration, and then there are skip areas that look fairly normal. So this sort of typifies what we see in Crohn's disease. Our therapies are totally focused on dealing with ulcerations. We don't have any good treatment for fibrosis, and this has sort of become the challenge as a clinician, is to how do you discriminate between narrowing that's caused by edema or by inflammation versus narrowing that's caused by fibrosis, and this remains a challenge. And then the hallmark of Crohn's disease is the granuloma. In ulcerative colitis, you tend to have more diffuse involvement. And you can also have a cutoff where you've got inflammation usually it's in the rectal sigmoid, and then there's an abrupt cutoff, and then there's a normal appearing area. And the hallmark for ulcerative colitis, which is also found in Crohn's disease, are crypt abscesses, which are shown in this slide, and also the development of chronic changes. You can't really have ulcerative colitis or Crohn's disease unless you have chronic changes, which are characterized by these branching of the glands and disruption of the tubular structure of the glands in the colon. So Crohn's disease is a chronic illness, and it's a chronic progressive illness. And our models up until very recently have been to treat it as an acute disease. So we treat flares of disease. And we are now starting to think about ulcerative colitis and Crohn's disease as chronic progressive diseases, that much in the same way we think about diabetes or hypertension. And that the goal is not really to treat the flares, but to deal with to deal with the avoiding the progression of the disease. And the treatment paradigm is really to try to prevent these flares by preventing their occurrence, not just to treat them. So it's important to initiate treatment early to impact the outcome, because if you can prevent these flares of disease, you can prevent this natural history of developing fistulae and abscesses and surgery and strictures. That's the goal. And biologic agents play an important role in this, because there are only two therapies that have been known to achieve mucosal healing. One is enteral nutrition. So nutrition is really an important part of treatment. I'm not going to discuss that very much today, but we're going to focus on the other treatment that is effective in developing mucosal healing, and that's anti-TNF therapy and possibly other biologic agents. So the crux of the issue is, where's the target in IBD? In diabetics, we know that the target to treat is a hemoglobin A1C. If you have a hemoglobin A1C that's less than 7, or some people would say less than 6, you have a much lower likelihood of developing complications of diabetes. For hypertension, the target is your blood pressure. We know that if you keep your blood pressure under 130 over 80 or 120 over 80, that you have a much less chance of developing a stroke or complications of hypertension. But what is that for inflammatory bowel disease? What is the target to treat? Is it mucosal healing? That's the current thought. Is that mucosal healing based on endoscopy, or is that mucosal healing based on histology? That's still an ongoing debate as to what it should be. So let's look at some of the biologic therapies that we have. Well, it's important to know the history of biologic therapies and of therapies for IBD, because back in the 1950s, when Dr. Di Lorenzo was just probably entering grammar school, or maybe even before that, the only drug we had was steroids. And then in the 60s, we developed thiopurines, which now have become sort of out of favor in terms of treatment. In the end of the 1980s, we had methotrexate, and then in the 1990s, we started to have experience with anti-TNF agents, and then in 2014, vedolizumab, biosimilars came along that we showed work just as well as the original drugs, ustekinumab in 2017, and now we've got small molecules like tofacitinib in 2019 and 2020. And then I'll show you in a little while that the portfolio contains a large number of biologic agents that are currently being tested for efficacy. So at the current time, anti-TNF agents are clearly the most effective medications that we have to treat Crohn's disease. And there are three that are currently available. Infliximab is certainly, and adalimumab are the most commonly used. Infliximab is by infusion, adalimumab is by injection, and certolizumab, which is a pegylated form of a humanized monoclonal antibody, is also available. And it's similar to adalimumab, but it's given less frequently, and there's just less experience with it because it's a newer agent. The data in all the biologic agents, and the top two are studies from adalimumab and infliximab, and the bottom are vedolizumab and ustekinumab. But the message is similar in all of them. You can see that the efficacy, the response rate at 2 weeks is around 60%, a little bit lower for vedolizumab because vedolizumab takes longer to work. But if you look at a year, the efficacy, the remission rate is about 40%, a little lower in infliximab, in vedolizumab and ustekinumab. But if you look at the overall remission rate, it's about 20 to 20%. And there's a little bit of difference. Ustekinumab may be a little bit higher, but the overall remission rate after over a year is not that good. You're talking about 25% of patients. So why, these biologic agents are effective, but they're not the only therapy. Something else is missing. And one of the thoughts of what is missing is the nutritional therapy. So there's a lot of interest now in seeing if the combination of nutritional therapy and what we know about nutrition and IBD in conjunction with biologic agents is going to be a way to increase and have a more sustained remission. So loss of response is an important aspect of treatment with anti-TNF agents. And when these drugs were approved, they were approved based on a dose that showed a certain level of response. That's how the FDA approved these drugs, which was appropriate then. There was no monitoring of the drug level, which now has come back to haunt us, because now with therapeutic drug monitoring, we know that we want to keep the infliximab level around 10 and adalimumab level over 12, and this prevents the development of antibodies, which then decrease efficacy. The problem is that the FDA approves the drugs based on a dose. So when you go to increase the dose for a patient that has a low level, the insurance company comes back and says, well, we're not going to cover that increased dose because it's not indicated. So this is work that we need to do going forward. But it's clear that the therapeutic drug monitoring is critical to monitoring the response to IBD. Can you imagine treating an infection with an antibiotic if you didn't know the susceptibility of the organism? I mean, it would not make any sense whatsoever. So, and that's sort of the stage we're in now, where therapeutic drug monitoring is really an essential part of treating. In fact, I don't think that you should, I'll go out on a limb and say, I don't think that you should start an anti-TNF agent unless you can monitor the therapeutic response in the trough level. Because higher levels may be needed in patients who have active ulcerative colitis, especially because anti-TNF agents are bound to albumin. And if you're losing albumin in your colon because of colitis, you're gonna have less efficacy. There's also some evidence that patients who have perianal disease may require higher doses to achieve mucosal healing. In acute severe colitis, especially if the albumin is less than 3, I would check a level after 1 week following the initial dose and give a second dose if the patient's not improving. And we have a patient in the hospital now who's a 7-year-old boy who has acute severe colitis, who had a response for a day or two after his first dose of 10 milligrams per kilogram of infliximab, which I always start with a higher dose in patients with ulcerative colitis. And he's now a week out and he's not responded, and he got his second dose early, and we drew a level to see what his level is, because if his level is high, then we know he's a primary non-responder. If his level's low, then we're going to give him another 10 per kilo to get his level up to above 12 to see if he'll respond. So you need to increase the dose to achieve a therapeutic level. And I've given patients as much as 20 milligrams per kilogram every week to get their level up to a therapeutic range. So there's no harm, there's no downside to having too high a level. The downside is in having too low a level, because it decreases efficacy and it increases the risk of having antibody formation. If you develop antibodies on therapy, adding methotrexate and increasing the dose can often get rid of those of antibodies and allow you to have better efficacy. We also, I think, in anti-TNF agents, we are much too quickly do we stop a medication for a reaction. We now have a program at our hospital where we do desensitization in the ICU for patients who have had significant reactions, anaphylactic reactions to anti-TNF agents. These are patients for whom there may not be another option for changing class of medication, but one should keep in mind that desensitization is something that can be done, and we certainly can share that protocol from the immunologist about how you do it, because it is effective in allowing you to continue using a medication for which a patient had a reaction. So the anti-integrin agents, right now, vedolizumab, anti-alpha-4 beta-7 integrin, is effective in patients usually with colitis. The therapeutic target is 15. So one needs to try to achieve that level. And in my experience with children, given a standard 300 milligram dose, that they are every 8 weeks, that they often don't achieve that level. And I'm ending up having to increase the dose to decrease the interval to every 4 weeks to achieve that level, even if the patient is asymptomatic. If the level is low, I increase the dose to achieve that therapeutic level. So these molecules, of which there are a whole number that are now in clinical trials, block the adherence of the leukocytes to the endothelial cells, and they prevent migration of the cells into the tissues. But they also block not just at the blood vessel level, but they also block the cells, the lymphocytes in the lamina propria from interacting with the intestinal epithelium and causing disruption of the epithelial barrier, which then allows for bacteria to cross. So they do a couple of things in the gut that decrease the inflammatory response, but they take about 6 weeks or even longer to become effective. So they're not beneficial in acute severe disease. And IL-12 and 23 are anti-IL-12 and 23 monoclonal antibodies, such as ustekinumab, are effective in some patients. And again, the therapeutic level to achieve is about 5. These medications are often effective in patients who have failed anti-TNF agents. The issue is we don't know how to predict who's going to respond to an anti-TNF agent and who's going to respond to an anti-IL-12 or anti-IL-23 agent. And I'll talk more about some of the biological markers that we're using in order to understand that better in a second. So ustekinumab binds to the P40 subunit of IL-12 and IL-23. There are now agents that are under clinical trials that bind only to the P19 subunit of IL-23, and they may be more effective. So in ulcerative colitis, again, infliximab, I think, is probably is my drug of choice in terms of using it. I think it's as effective. It can be as effective as adalimumab. The issue is that you can adjust the dose of infliximab more easily because it's given by vein. I usually start with 10 milligrams per kilogram in a patient with ulcerative colitis, because I think they require higher doses to achieve remission. In patients who are usually outpatients Golimumab is an injection. It's a little bit different than infliximab in that it binds to both the soluble and the transmembrane forms of TNF alpha. And so there are some patients who may respond better to golimumab as a maintenance drug than infliximab. And finally, vedolizumab again it can be used as a maintenance drug in ulcerative colitis. I want to go back to this slide that I showed because I think that it's important that we realize that that these medications, while effective, may not be the only medications or the only treatments that we need for long-term therapy, and we need to think of other ways to approach this. So nutritional therapy, I think, is what we're considering might be missing in terms of long-term therapy. So what are some of the predictors of response to therapy? What crystal balls do we have to say which patients are going to respond to anti-TNF, who's going to respond to an anti-integrin, or who's going to respond to an IL-12 or 23 molecule? Oncostatin M is a biological marker that's found in tissues, and it's been associated with a high level of this protein has been predictive of a poor response to anti-TNF therapy. So this is just the first of many molecules or biological markers that we hope will be of benefit in predicting who's going to respond and who's not going to respond to therapy. Dr. Anesra Krishnan, who's at Mass General, published a recent article looking at the metabolomics of the stool and showed that having a higher abundance of butyrate producing bacteria in the stool was predictive of a response to anti-integrin therapy. So there are biological markers in the blood. There are potentially biological markers in the microbiome that might be able to predict who's going to respond to therapy and who's not. More to come in this area, certainly in the future. So the therapeutic paradigm that we have in this era of what's becoming personalized medicine. You know, it's not the idea that if you've got a strep infection, you get penicillin. It's the idea that you know, looking at the risk factors that an individual has, looking at the metabolic pathways that are impacted by the disease in that individual, and looking at predictive biomarkers, and then looking at therapies that to treat to the target. And if that target's mucosal healing, you know, looking at therapies that treat to that target are really the ways to personalize the therapy to an individual who has Crohn's disease or ulcerative colitis. So the drug pipeline is really robust, and I know you can't see these because the intention is not to see them, but to make the impression that there really are a lot of drugs in different classes: anti-adhesion molecules, anti-lymphocyte, microbiome targeted, barrier agents, regenerative agents, anti-cytokine agents. There are a number of agents that are in the marketplace, but the new biologics that have come about in terms of JAK1 inhibitors, these are small molecules, and tofacitinib or Gelzans is approved for adults. It's not approved for children for ulcerative colitis, but just in the past few weeks, it was approved for children greater than 2 years of age with juvenile idiopathic arthritis. So I have this patient in the hospital now who's not responded to anti-TNF agents, and the discussion I had before I came to join this talk with our fellows was whether or not to start tofacitinib tomorrow in this patient who's failed anti-TNF agents. And so that's a discussion that we're having, but I think it's one that now that the drug's been approved for children over 2 years of age, I certainly feel more comfortable using it off-label in the child with arthritis. These other small molecules are in development. IL-23 inhibitors are in development. Mirikizumab is a specific IL-23 inhibitor that is undergoing clinical trials right now for ulcerative colitis. We have one patient who's enrolled in the mirikizumab trial that Dr. Jess Kaplan in our group is leading, and we're hopeful that this drug will provide an alternative to ustekinumab and be effective. And then there are a number of anti-beta 7 integrin inhibitors which are currently being tried. And then there's a class of medications, sphingosine 1-phosphate subtypes, which are also small molecules. Ozanimod is one such. And yesterday there was a presentation oral presentation at the IBD meeting that's being held virtually, and they reported yesterday that a trial of ozanimod decreased fecal calprotectin and decreased lactoferrin in patients with ulcerative colitis, suggesting that this was a promising new therapy and that it decreased the inflammatory response. Mesenchymal stem cells have been used now for healing fistulae and are very promising in terms of a new therapy for closing fistula that have been refractory to antibiotics and to anti-TNF therapy. And finally, I heard Hans Cleaver gave a talk 2 days ago about organoid treatment. And this was just spectacular how in animals, they've been able to use organoids to attach to areas of ulceration in mice that have ulcers, and the organoids attach to the areas of ulceration, and then they spread out and grow and they heal the ulcers. So this is a potentially really promising treatment for in going on in the future. So the take-home messages from this talk about new biologic treatments are that children often have high TNF levels, and they often require higher doses of anti-TNF to achieve similar outcomes. That infliximab for acute severe colitis is probably the drug of choice because one can adjust the dose, and oftentimes if we see failure in acute severe colitis, it's because we haven't dosed patients adequately, and they may need to have much higher doses, especially if they're losing drug in the colon with low albumins. And measuring trough levels for anti-TNF agents is essential, and it's probably essential, although there's much less data, especially in children, in both the anti-integrin and the IL-12/23 agents, to know the benefit of therapeutic drug monitoring. But by extrapolation, it certainly is reasonable to get into a therapeutic range. And higher doses of anti-TNF agents are probably needed to treat some forms of Crohn's disease, especially perianal disease and ulcerative colitis. And there are some preliminary studies going on now where patients who are refractory to treatment with anti-TNF agents are being treated with combination therapy of anti-TNF agents and vedolizumab. These trials are just now underway, and there's not a lot of information, but it's something to think about in the future. And again, think about nutrition for patients who are on long-term therapy with biologic agents, because biologic agents may not be sufficient to sustain someone for a lifetime of remission. And with that, I think I'll end, and thank you so much for your attention, and Assalamu alaikum.
Thanks a lot, Professor, for this excellent, highly informative lecture, actually, on the update and the new therapy of IBD and the new biologic therapy in the IBD. We have a few questions. We will start with Professor Lorenzo. So Professor Winter can relax for a few minutes after this long talk. We will have the first question we have, Professor Lorenzo. How would you manage children with sacral hypoplasia or agenesis?
Yeah, those are always challenging because they have an anatomical problem that often leads to a physiologic abnormalities. It really all depends how intact the sphincter function is. If the sphincter, as often is the case, is incredibly weak or is not even barely detectable, then I found that antegrade enemas through a cecostomy or appendicostomy is a dramatic quality of life improving intervention, very much like in patients with spina bifida or myelomeningocele. Basically, if the outlet is wide open all the time, cleaning the entire colon from the top down with an antegrade enemas often is the only way to achieve 24-hour duration of continence. So now, if the sphincter is still somewhat functional, then you have all sorts of other intervention can work. You can still try all your medical interventions. One thing that I tend to stay away from is the stool softener. Stool softener sometimes make the stools so soft that are it makes it impossible to hold them in. I try, once again, I use a lot of stimulant laxative because they give you one good cramp and they empty the entire, most of the colon. And then you don't have to deal with very, very soft stools like you get with stool softener. So if you have some sphincter, stimulant laxative. If you have no sphincter, antegrade enemas.
The second question, thank you very much, Professor. The second question is actually about for how long we can use stimulants as a maintenance therapy.
I don't know that there is an upper limit, to be honest. For some reason, families always get worried about using stimulant laxatives. And I always ask them, do you use acid suppression for reflux? Do you use medications for asthma on a chronic base, Singulair, Zyrtec? Nobody gets upset about those medications. But for laxatives, people get always upset about laxatives. So I try to wean them from the laxatives. And sometimes it's very easy, sometimes it's possible. Other times they still need to be on. You can use it as needed. If they don't have a bowel movement for 48 hours, then you need your stimulant laxative. But if somebody needs stimulant laxatives every day, because if they don't take it, they're not able to have a bowel movement, then it's fine with me.
Okay, Prof, there is a question, actually, one of the audience asking, what is the indication to use enema in children in the case of constipation? I think,
Yeah, so enemas is interesting because it's very effective, but is deemed to be somewhat invasive by many children, especially children that have stool withholding. They are afraid of having a bowel movement. They find the defecation painful, and giving an enema sometimes convince them even more that this is an act to avoid at all costs. I find, for example, in some patients with cerebral palsy or spinal defect, they actually don't seem to mind the enemas as much. They do very well with that. They don't have such a hypersensitive perianal area. So in those patients, the parents sometimes tell us, I rather give them an enema because I control when they're going to have a bowel movement. Is under my control. Is a family life improvement. So in patients that they don't mind it, that's actually a very effective way to deal with it. I tend not to use them much because most of my patients hate them.
For how long you can go with the enemas? I mean, usually we use it for fecal impaction, and that's.
Yeah, but yes, you're right. Usually we use them to soften the stools with the fecal impaction, and sometimes then we wind them out, sometimes with oral laxative. But I have patients with cerebral palsy, with severe developmental delay, that have been receiving an enema every day or every other day for 20 years. And that's the way the family has elected to have control of the child bowel movement, and to avoid leakage, to avoid incontinence, to avoid perianal inflammation. So I don't think there is any problem, physiologic problem. There may be a psychological problem getting enemas every day, but there is no physiologic problems that I can see in getting enemas every day.
That's right. Last question for you, Professor, before we shift to Professor Winter, is actually when you have a patient for the during first visit with you in your clinic with a child who has a chronic, a functional constipation, what are the routine investigation you do? This is one of the questions from
the vast majority of patients, I would say 90% of the patients, need absolutely no investigation, not even checking thyroid, not even checking labs for celiac disease, no investigation at all if the history is classic. Child that crosses his legs, hides in the corner, refuses to sit on the potty, has a history of large, big bowel movement, they hurt when they come out. What investigation are you going to do? There is really no need for any investigation. Sometimes I do an abdominal x-ray just if I have to determine how aggressive I need to be with a clean out. I believe that a good starting point in children with chronic constipation is to have a clean colon. So I tend to do a good clean out to start with. And you can either do a rectal examination, but sometimes it's really hard for many reasons, obesity, behavioral problems, family opposition. So either you do a rectal exam, or sometimes I get an x-ray to see how impacted they are, to find out how much medications I need to give from below or from above. But otherwise, in the most of the children I see, no investigation is required, at least at the first visit. If they fail all medical treatment, yes, then you do, I don't know, biomenemin or rectal manometry, whatever you want. That being said, I'm saying that only in the child older than 1 or 2. If this was a 3-month-old at the time of the first investigation, that changes everything. In a 2-month-old, 3-month-old, then I get a lot more worried.
Prof, one more last question. It's in which cases you use the Botox injection, and do you do it yourself or you refer it to the pediatric surgeon to do?
I do it myself. It really doesn't require a lot of skill. I have to be honest. You probably want to see 1 or 2 done by the surgeons, but I basically dilate the anus with a vaginal speculum or nasal speculum, bend the needle of an insulin syringe, and I inject the Botox in the 4 quadrants. So it's a very easy procedure. I tend to do it in patients who have failed medical treatment and in whom I sense that there is an outlet obstruction, an outlet process, where they have a hard time getting the stools out, they have severe stool withholding, they failed everything else, and or in patients who have a history of Hirschsprung disease and rectal malformation and so on. But
thank you very much, Professor. Go ahead. I'm sorry that I interrupted you.
No, I was saying just it's very simple. Don't be afraid. I say the same thing for pyloric Botox in the patients with I told you about gastroparesis. For some reason, Botox is very expensive, but it's very easy to inject and to use.
Yeah, for those patients with Hirschsprung pull-through operation, thank you very much, Prof. Professor Winter, there are a couple of questions. One of the question is how high anti-TNF level you target when treating a severe acute ulcerative colitis? Means after the first induction dose, how much high level you prefer?
Well, so that's a very good question, and I wish I could answer it with some evidence. I think it's that the level that we target for somebody who is on chronic therapy as an outpatient is around 10 for infliximab and around 12 for adalimumab. But for a patient who's in the hospital with acute severe colitis, who's having multiple stools a day, is has a low albumin, and we don't really know what the level is. But I would, and so if you give a dose, a first dose, and you wait 2 weeks for the second dose, which is 0.26 is the usual induction. What I would recommend is after a week, if the patient is better and has had a response, then one can wait for 2 weeks and do the second induction dose and check a trough level before the second dose. And then, use that information, because the next dose is going to be 4 weeks later. So if that level at 2 weeks is 12 or 10, then one knows that in 4 weeks it's going to be much lower. So I might think about giving a dose 2 weeks later rather than waiting 4 weeks. There's not an absolute number, but my guess is that it may take the doses around 15 or 20 in these short intervals if the patient's having a lot of diarrhea, to capture the disease. But that's a total guess. I mean, we don't really have that information. You have to look at the level in the context of how the patient's doing. So the first thing is to look and see how the patient's doing. If the patient's responding and they have a level of 8 or 10, then that's fine. If they're not responding, that's when you have to think about whether to increase the dose or not, because that's when you have to decide whether or not you have a primary treatment failure, in which case you may want to go on to a different class of medication.
Prof, there's a question that how do you desensitize, I mean, maybe before shifting to another anti-TNF? Do you do the desensitization before?
Well, I think it depends upon the patient. I mean, so I think if the patient has just failed an anti-TNF, then one has other options, vedolizumab and ustekinumab. So one has options. There's no reason to desensitize. The patient that currently we have who's being desensitized is a patient who's had Crohn's disease since she was 6 years old, and she has failed every medication, both anti-TNF agents and ustekinumab and vedolizumab. She's failed, and she also failed Gelzans. So we decided to treat her with infliximab because she had responded to infliximab in the past, but she had an anaphylactic reaction to it. So that's the kind of patient that you would think about doing a desensitization in.
Yeah. I think this is a question which is maybe it's a loss of response to anti-TNF. What is better to do first? Is it increasing the dose or decreasing the frequency?
Right.
Or it depends on the physician choice.
Well, if you have a patient who has a low level and has lost response, and the treatment is to get the level up, so to increase the level, you're right. You have two options: either you decrease the interval or you increase the dose. So some of this in the United States is driven by the insurance companies, because it's always a struggle to get more than 10 milligrams per kilogram, whereas it's easier to decrease the interval. So if you decrease the interval from down to every 4 weeks, so if the patient is getting 10 milligrams per kilogram every 4 weeks and they're still having symptoms and their level is still low, then I think that one would increase the medication, so increase from 10 to 15 milligrams per kilogram. One can decrease the interval if you need to. In this one patient who I had, we increased the level to 20 milligrams per kilogram every 4 weeks, and she still didn't have a therapeutic level, and had antibodies. We added methotrexate, and we ended up having to give her 20 milligrams per kilogram every week for about 2 or 3 weeks in order to get her level into the therapeutic range. And then when we got the level into the therapeutic range, she responded clinically, and we were able to increase the interval back up to every 3 weeks of 20 milligrams per kilogram. So I was measuring her trough level with every single infusion, because that's what we needed to do in order to decide how to treat her.
Okay, thank you very much, Professor. There is a question saying, can we start from beginning by adalimumab instead to start infliximab?
Certainly, you can start adalimumab. I mean, for acute severe colitis. you can use adalimumab or infliximab. I think it's easier. It's easier to dose infliximab, especially in young children. It's easier to dose because you don't have you can adjust the IV dose easier, and you can manage the dose. You can manage the dose with therapeutic drug monitoring easier with infliximab, but you certainly can. They're both effective. And adalimumab is used a lot more in Europe, for example. A lot of this is insurance driven, but they're both effective in ulcerative colitis and in Crohn's disease.
Some parents actually prefer, because adalimumab they can give it as outpatient and they don't need admission. So when the parents they know about it, they actually prefer to give that adalimumab.
They do, and a lot of college students prefer to have adalimumab because they can do it at college, and so that's also a consideration that one needs to make. It's an individualized decision whether or not to do that. But for acute severe colitis, for a patient who's hospitalized, who's in the hospital, and having multiple bowel movements and has a PUCI of 65. Adjusting the dose with infliximab is easier than adalimumab, but they're both can be effective.
Thank you very much, Prof. Thank you very much. There is one last question for Professor Lorenzo, which come just now, a couple of minutes back, and I think I have to ask you, Professor, because just to for this impaction of infants, would you recommend to use PICO preparation?
We don't have PICO preparation in the United States. Our colleagues in Netherlands use it all the time. I tend to use either saline, normal saline, or bisacodyl containing preparation. But PICO, from what I hear from my colleagues in the Netherlands and in Italy, it's a very effective intervention.
Thank you very much, Professor. Thank you very much, Professor Lorenzo, Professor Winter. And I would like also to thank the audience. Sorry for keeping you late in this evening. And we would like also to welcome Professor Muhammad Al-Mawzan. Salam alaikum, Professor Muhammad. And alhamdulillah as-salama, Prof. And inshallah, tomorrow we will have the continuation of this very fruitful and highly informative course, actually. Thank you very much, and thank you to Professor Asad Al-Asiri. Professor Asad, if you have any words to say.
I would like to thank Harland and Carlo for this excellent presentation. I would like also to thank Dr. Ashraf Sahafi and Professor Badria for being an organizer for this excellent talks. I would like also to thank our audience for being with us tonight. I would like to say welcome back, Professor Muzan, and we are quite happy that you joined us, and you always, inshallah, keep good health. Thank you very much. We'll see you tomorrow at 7:30. And hope to see you, inshallah. Thank you very much.
Thank you.
Bye.
Bye-bye.